I hope I speak loud enough for you. If you can't hear me, please tell me, okay? Yes, my journey with HA, that's a long journey, to be honest. And I hope I don't bore you, but some of you I know, like Alex, 30 years, and Marina, probably 30 years, or 28 years. Because my journey is in this field 28 years now. These are my disclosures, and this is my clinic. It's an old, really two old buildings with a surgical facility. And Gerhard and I, my husband, we founded it in 1996. Actually, I always say it's built on fat. Because my husband used to do a lot of liposuctions, and this clinic performs still per day 5 till 7 liposuctions. And of course it grew, and we, at that time when we started 1996, 1997, we really injected autologous fat as well as collagen. Collagen superficial after a test on the arm, superficially into the maximum dermal layer. And this was a long pathway, I can tell you. So my subdivisions today are a research center where I was lucky enough to be chosen by Stefan and Halura for the first bigger study. Then I have 2 walk-in clinics, one in Frankfurt, one in Hamburg for minimal invasive only, and a kind of a medical spa which takes care of after surgical procedures. Today we are like 18 doctors and about 120 people working for me. But when I look into the hyaluronic acid history, you know, we started in 1997 actually with our clinic. Restylane was approved 2003 in the US, and at that time, at least in Germany, hyaluronic acid was Restylane because collagen was called collagen. Yeah, so we mixed it kind of. For us, hyaluronic acid used to be only Restylane, and then we found out, in comparison to collagen, it has a high swelling capacity. So we used to do fat for the tear trough area, and we loved it very much. Myself, I still have fat from that time in my face. But when we used Restylane, we had all these swelling suddenly. So something totally reacting differently. Then 2006, Juvederm Plus and Juvederm Ultra Plus, that's how it was called in the US, came to the market. With us, it was called Juvederm 3 and 4. And actually, we liked these products. We liked the products because they were quite easier to use. No allergy test before. And we played around. At that time, I can remember my first patient, I took like 6 to 8 syringes and flooded the face. And actually, she looked nice. We had no clue about anatomy. It was really learning by try and error. And of course, more and more companies brought different HA fillers on the market, and the European approval, you need to understand that, and I don't understand why, is so easy. Until today, it's so easy. I think we have like 60 HA fillers on the market. So the regulatory is becoming now a little bit more difficult, but in the US compared, I think you have like 1/5 of our filler products on label on the market. So we started then injecting deeper. Okay, we started to put the products deeper, and suddenly we also had more cross-link products. Like in Europe, the Voluma from Allergan, Juvederm Voluma was the first product cross-linked on the market. At that time, in its 2 ml syringe, and we played around with longer and better results, we thought. We had no clue how long it takes when it's out. We now know some of these products sit, they are like glue on the bone when we inject them deep. And with this, we thought we have something better. But parallel to this Voluma, also other products came to the market. Kaha at that time already as a filler, PLLA for HIV patients as a filler, as well as all these mixed products with HA called Articol, Dermalife. These were fillers which had PMMA, so non-resorbable microspheres included for a so-called permanent result. And we saw a lot of trouble. I still follow up, like Ophir, probably all of you, patients who had 1 syringe only in that time, and they come every 6 to 8 weeks, need some corticosteroids or 5-FU, otherwise they can't drink, for example, because they had 1 syringe in their lips. Horrifying. These 2 guys, and probably the first one nobody knows, that's Professor Anderhuber. Professor Anderhuber from Graz, Austria, was the first ever conducting a cadaver training for dermatologists with minimal invasive injectables in 2005, at least in the European, my world, let's call it this way. And he gave the first anatomical lectures in the Life Surgery Symposium before we then injected, 2006. Then Sebastian, you all know him, Kotefana, came the first time ever in his life on stage, also in Germany, during our congress, and did a cadaver dissection. So before all that, we had no clue what we were doing, okay? And the industry reacted on that because we were now thinking about volume, injecting deeper, injection techniques. So see, these were these life surgery symposiums. And we looked into research more. We wanted to understand what we have because we started then already, let's say 2008, 2010, seeing swelling after teeth cleaning. It started early, but you know, the patient couldn't really connect it to the HA in the face. Even today, you have to ask your patient, did you have an issue after your last dental appointment? I think they cannot connect swelling with our treatment maybe some years ago. So this is my research facility, and I can only emphasize everyone, this is a very strong pillar in my development, and I've seen horrifying products, which, well, they will never come to the market, but you know, every company is again and again trying to mix things into each other. It's not working. You know, we should understand what we have in our syringe. I think we should really be very clear with that. And this is, for example, one of these volume filler patients. Of course, she had also upper blepharoplasty, but you can keep those patients with volume only. We thought at that time. But when you see then what Shannon Humphrey published, and Ophir showed, and I will show tomorrow too, this publication, 1% of these patients will have an issue. 1% is 1 out of 100. I think that's a lot, because you will lose this patient forever. I don't want to lose my patients. I want to give them the best. So injection technique, of course, you know, especially these companies who provided article, they said, if you inject it deeper, then you will have no problems. I can remember all these discussions. But you know, also deeper, we are biology as a person. We have an immune system also deeper. So why, maybe we don't see the issue of the granuloma early enough, but we do something to our body. So deep injection techniques, we played around a little bit. Then we played around about this sweet spot technique, mandibular, jawline, mandibular ligament, inject deep into the ligament. All these things, because we didn't really know what we were doing. Okay? Tower technique, at that time we thought better not above the bone. Tower technique can blow up faces. Even if my wonderful husband invented more or less part of the tower technique, but I think for many patients it's far too much. So we learned during these years quite a bit. And when you look at the statistics of ISEPS 2022, millions of people down here, women, 3.7 million will become HA in this year. This is ISEPS worldwide. And also male picking up. So we speak about a huge business, yes, but also we inject something into the human body million times. And don't think, if we think about BDDE, that everything is degraded until you inject again. It will add up over the time. And I mean, in our age, maybe we started with 30 with the first syringes, in my age now. But other patients come with 60 first time. Now the patients come with 20. looking into 50 years of 5 decades of injectables. So we should be very sensitive to know what we are doing. Today we think about layers, you all know that. And then we think about the right technique, again, needle and cannula. And I truly think we have to be open to both. I think we have very skilled injectors with needle, and we have very skilled injectors with cannula. And I think cannula is more difficult to inject it correctly. So this is how we started. I showed you that. And the assessment, I think, is the biggest difficulty in every patient every day. Also for me, after all this time. And the assessment is also always visual and manual. Manual means touching the face. So if Ophir shows these nice pictures after Hallura, I promise you, when you touch it, it will also show a more haptic density than it was before. Okay? So, and then of course we have the treatment plan, diagnose, we all know that. And we all know that. Stiff faces, too much toxin, stiff faces blown up with HA. And so what shall we do? We have all these in Germany, 60 HA products. Which one do we take? The cheapest one or the one which shows, well, the nicest sales rep coming in? No. I think we are really expecting safety, long-term safety, tissue integration, natural look, long-lasting results, meaning regeneration of your own tissue. So this is another BDDE paper. We all know that BDDE has a toxic, is toxic to our body, and maybe we add up over time, and maybe we accumulate even BDDE in our body. You probably all know this Greg Goodman publication. It's really about the inflammation, what we induce with HA. How much we will induce is depending probably that we think today on the chain length of the HA. So here you see the blue is the filler. Here you see chronic inflammation, macrophages, lymphocytes, and also giant cells in the yellow one. When we inject the filler, hopefully as sterile as possible, and we still have a filler with a longer chain or high molecular HA weight, we still think it's anti-inflammatory. That's what the orthopedics do. The longer the chain, the better the anti-inflammation approach, and they use it anti-inflammatory. And maybe we take some surface pathogens with us down there, if you're not sterile enough. But usually these are human common cells. Usually our body can deal with that. But what happens when we degrade HA into shorter chains or by toxic reaction, reactive oxygen species, for example, ROS? Then we have shorter chains by degradation. And then the inflammatory potential seems to be much higher. So products who have a short and a long chain and then mix them together, BDDE or however, seem to have a more potential inflammatory response than those who have the longer chains. So this is Shannon, Ophir, you showed it. I think if you look at 4,500 patients and have 1%, for me that's, I don't want to have any. I sleep best when I have no issues. We all have issues, we know that, but the issue should be not through the product. I think we should really look and understand our products. Ophir made it happen that all these people, we were all included more or less, brought in together an algorithm for late onset reactions. And at that time, we thought a lot about adding antibiotics. So most of the filler reactions I see are sterile, sterile nodules. And so nowadays, I'm more going to the hyaluronidase as well as into steroids quite fast. And then not in this nodule, but more orally over time. So now we have the young generation, Gen Z or Z. They are regularly working out. They are eating vegan. They understand a lot more. They check themselves with all these selfies. And then they want to know what you're injecting in them by the toxin and by the filler. So this all filler fatigue or whatever comes a lot from this generation because they're afraid to look like Madonna. They're afraid to look like a puffy face. They want to stay healthy, but themselves. So I think this generation really asks us to look into safer regenerative approaches and not just to use a cheap filler and inject them somewhere deep on the bone. I think, Chino, you can explain that much better than me. But I think we have to understand that with the regenerative aesthetics, we really want to keep up our own cell function and let them work for us. Stem cells, our fibroblasts. So we want to really keep them working as if we are 25. So the outcome is our own collagen, our own keratinocytes, our own fat cells. The outcome is not through an injected filler. So that's a total different approach. And new products, I mean, we didn't speak before, Ophir. And I'm not speaking for this company, but it's interesting. This is a Profilo. And I don't like that it's a low and a high chain, actually. But they brought the second product now on the market in Germany called Profilo Structura. It's only heat cross-linked with no BDDE, no other substance. And with this heat cross-linking, they did in vitro tests for fat stem cells. And they showed this hybrid complex with heat cross-linking activates fat stem cells, and compared it with other HAs, or only their long chain or their short chain. And only the complex did the best stem cell activation in vitro. So their approach is not to fill a wrinkle. Their approach is to regenerate areas. The Structura, they say, only pre-auricular you inject, and your whole face will be regenerated. And I thought, what are they talking about? You know, but then I used it, and it's amazing. My patients really like it. It's amazing. So you see, they have these publications in vitro. Keratinocytes will be have an uptake, fibroblasts, adipocytes. And now we come to Hallura. I mean, Stefan will sentence that, we didn't really know what we were doing also. You know, we had this new HA product, new cross-linking, and completely different, the so-called BioLink matrix. And you know, we had a study planned for 12 months. But then we looked at the patients and they didn't degrade. And I have to be honest with you, I thought, oh my God, maybe this cross-linking is not degradable. Yeah, because with a 4 milligram or 6 milligram HA only, why should a lip last for 15 months? How can that be? So we know now it's degradable, that's true, but it's a longer lasting effect. And maybe if we would have like a circular approach, like every 3 months, maybe we can have like a regenerative approach and a long-lasting, very long-lasting effect. So we don't know that all yet. So I think there's a lot to do. But what we know is that the Hallura is the only one which keeps, by this biomatrix cross-linking, the long chain. Mostly as it used to, you showed this other picture of here, as the original HA chains which you can buy to produce hyaluronic acid products. So that's a big, big difference. And the longer the chain, I told you before, the lessest inflammatory potential an HA has. It's anti-inflammatory. And we did these patients, I think we were three, so it wasn't only with us, but it was an amazing study. And you see, we didn't stop at 12 months. We followed up some of the patients 15 months and some even 18 months until we saw that it started to reduce again the lip volume especially. And super natural results, very natural results. Also cheeks, well, you saw enough pictures from Ophir. Even a little plumpier lips had very nice long-lasting results, 15 months here. Okay? So Ophir and I met and I said, this is something, Ophir, you're from Israel, why don't you know about that? It's something different, you know? And of course. Sorry, that's one only, yeah, 4 milligrams. So there are many players in our skin. And I know Ophir is playing around again with the biostimulators on top of that. We need to understand a lot what these cells do and how we can keep up their function. I think we are just on the start here. And we have different products. HA on the one side, then fibroblasts, induce extracellular matrix, elastin fibers, collagen fibers. How can we ask them to do more elastic fibers than not only collagen fibers? Because collagen fibers are rough. I mean, they are stiff. Too much collagen is a fibrosis. We don't want that too. So we have an orchestra. Nowadays we have an orchestra. And I don't know all of you here, but I'm sure only those who really inject regularly know what they're doing. Others buy, like in Germany, dermatologists do maybe 80 patients a day, 1 or 2 maybe aesthetic. The rest is dermatology. It's fine. But you will never develop yourself when you do only 1 or 2 patients a day. And you have no clue what you're doing, actually. Because now, in a patient like her, and you don't need to read all that, mid-face augmentation, I did many, many things in one session. I go through that, even with Kaha superficially, and I'm not the mixer in one syringe, you know, I'm the one who separates it in different layers. And we don't need to look at this really, but I think we need, these are 4 different products used in one day. I don't know what this does inflammatory to this patient. Deep injection, superficial injection, posterior temple injection, and then subcutaneous biostimulator, and on top a little bit skin booster. So we know there's so many things we can do, and I show you just the after, 10 days after. Only injected in the mid-face and posterior temple. But all these products will have an approach to our immune system. We need to understand that, and probably we should spare that better, not in one day. Maybe we should spare it in 4 weeks apart, then understand what the product does. But our patients ask us to do so because they are not educated so far to understand regeneration. I think our patients are unhappy when they cannot see the result in the beginning. So we are kind of a problematic pathway, and I love the idea of here. It's not a filler. Allura is not a filler, definitely. And for a patient like her, I would add then a microfocus ultrasound. You know, now we do heat and energy on top of biostimulation or HA. So she had regularly toxin and fillers, and then you add up the energy base, and then you have even a nicer result. Okay? But what we do to these patients, in the patient's cells, we now are starting to understand, not more, I think. My conclusion is we are aiming for regeneration and long-term safety in our patients. Our patients will have aesthetic treatments 5 decades. And I truly love this new BioLink matrix, Allura. It's a different product completely. I truly also love that it doesn't have too much HA in. And maybe we should have it injected like you did over here, 4 ml all over the face regularly, spared 3 months, I don't know yet, we will find out, as a regenerative matrix all over. All patients showed natural results, and the long-term result, long-lasting result was completely unexpected at that time. And after using all these years BDDE products for more than 20 years in my hands, it's probably a good time to think of something else now. And there's much more to discover. We need a lot of more research. So thank you so much.
Always, I'm going to steal your microphone. Always great listening to you. So if you talk about regeneration, and we all talk about regeneration, there is one person, one talented person, that Trump has actually called him to change his family name from Aguilera to Regeneration. So, Chino Regeneration Aguilera.